We're gonna switch to English, guys. So now welcome Marshall, welcome Dr. Ferris from Liverpool. Are you guys there?
I'm here.
It's great to have Marshall. Marshall, you know, works with us for a long time, knows this machine better than I don't think anybody, you know, in this earth. So he's gonna be helping us and you know, to show how this machine can help us in our learning curve. And Dr. John Ferris, are you there, John?
Hi, nice to be with you all.
Well, great to have you. Thank you for being with us. It's an honor to have you.
No, it's very exciting to be here. Thanks for the invitation.
Yeah, so the little introduction is Dr. John Ferris works in United Kingdom, and he is very involved in cataract training. He has done a lot of research. He works with virtual simulation, artificial eyes, has a very impressive background, amazing research that we're gonna jump into it. So John, please, some words for the audience.
Well, it's very exciting to take part in my first webinar, having done the podcast with you, Ivor, earlier in the year. And a great topic to talk about, really, something which not only for trainees, but also for established surgeons, I think this is highly relevant, the practice, the management of posterior capsule rupture, because if it's managed correctly, the visual outcomes should be excellent. And the role of simulation, both with the IC and model eyes working together, hopefully at the end of this hour, people will have a clear idea of how they can practice managing this relatively rare complication with confidence.
Amazing. So we are, what do you think? We're on English time. It's perfect timing, and we're gonna start in order to you. So let's see if you guys can see the slides. And okay, so we still have 1 minute. Let's see if I have to thank, you know, the audiovisual team. These guys are amazing. If you could imagine what's happening here, you know, with so many cameras, with slides, with the signal from the simulator coming out from here. That's one. That's the correct one. So we can start. There you go. First slide. And Marshall, we can start.
Okay, you ready to start us off?
Yes.
All right. So my name is Marshall Dial. I'm speaking to you from Toronto, Canada. It's my distinct pleasure to be the host of this webinar. I want to explain the purpose of this. Every day on the internet, there are dozens of very well-intentioned colleagues of Dr. Ivo and Dr. Ferris sharing knowledge in a traditional didactic manner. I've had the pleasure to watch many of these webinars, and having observed this and talked to Dr. Ivo a little bit, we came with the idea that maybe there was an opportunity to push the boundaries of learning through this interesting platform called Zoom and Facebook Live. So we're going to see if we can do something different, taking technology both for surgical learning in the form of simulation, and then combining that with the power of online learning platforms like Zoom. So this is, to our knowledge, the first live virtual surgery course in the world. And we're very excited to do this. It's also on a topic that's very relevant to every ophthalmologist learning their craft. I'm excited to hand off now to both Dr. Ferris and Dr. Ivo, who are amazing surgical teachers, having worked with literally hundreds of ophthalmologists all over the world. These are two gentlemen that are absolute amazing educators. So you're in good hands. And with that, we're gonna move on to the next, and that's Dr. Ferris's amazing groundbreaking research on this exact topic of managing posterior capsule ruptures.
Thanks, Marshall. Yeah, for the next couple of minutes, we'd just like to talk about the Royal College of Ophthalmologists National Ophthalmology Database study, which looked at the impact of IC training on PCR rates, posterior capsular rupture rates for first and second year trainees. In the UK, the training program is 7 years long. So these are junior trainees in their first and second year. There were 265 surgeons enrolled in 29 different hospitals. And in 26 of the hospitals, trainees had access to an IC simulator either in that hospital or in a hospital close by. And in 6 hospitals, the trainees had no access to an IC. Now, using an electronic patient record called Medisoft, all the results of surgery are recorded in these units. And the National Ophthalmology Database has just over 1 million cases on the database from surgeons of all grades. So we looked at the first and second year trainees between 2010 and 2016, and that came to just under 18,000 cases. And when we looked at the results of their surgery, the PCR rate in those hospitals which had an IC or an access to an IC fell from 4.6% to 2.45%. So that's a 38% drop in PCR rate for those trainees who had access to an IC. And in the hospitals where there was no access to an IC, the PC rupture rate fell in those 6 years by 3%. So if you equate that to the UK as a whole, where we do 450,000 cases a year, 5% of which are done by first and second year trainees, that equates to 450 fewer cases of PC rupture per year. And this was the first paper in any surgical discipline that had shown a reduction in complications in live surgery as a result of simulation treatment. And the slide to the left here shows that the case mix for before IC training, after IC training, and no access to IC training was exactly the same. In other words, in those hospitals where there was no access to an IC, the difficulty of the cases was at exactly the same level as in those hospitals which did. So this was not a confounding factor. And the Medisoft EPR lets you assess that. So trainees were only operating on relatively straightforward cases. And this paper will hopefully make it easier to acquire funding for simulation, because the money saved in reduced litigation and reduced cost of treatment to patients, never mind reduction in morbidity such as endophthalmitis and retinal detachment and cystoid macular edema, will hopefully mean that we can get funding for simulation from clinical budgets, not just from educational budgets.
John, I think we need to, let's go, I think we need to go to the numbers, right? 265 surgeons, around 17,000 procedures, 6 years, and 38% reduction. I think this is so important for the community of cataract surgeon teachers, trainers, that we need to, at least we need to be aware of this new technology that is changing completely the learning curve. See, before you answer, we're going to ask the people, the audience, to answer these questions, and we can hear your answer. Sorry. Please, we're waiting for your answer, John.
So answer to, sorry, I didn't quite catch the question.
What do you think if these numbers are powerful? I think they're very powerful.
Numbers, and the only reason why we could do this is because of the electronic patient record that we use, which you have 100% data capture. And when you're looking at relatively small complication rates, even before training, you need those sorts of large numbers to demonstrate an effect. And the UK is lucky in that 80 to 90% of units use an electronic patient record that allow us to look into all sorts of issues regarding cataract surgery. But the importance of this is that if there were ever any doubters, Ivo, that simulation worked, this really is proof that it does work, because some of the older surgeons, you know, who didn't have access to this form of training think it's not necessary. And, you know, what's the point of simulation? Well, this shows just how useful simulation is. It's now mandatory in the UK for all UK trainees to have completed their IC training before they then go on a surgical training course, which is a 2-day course at the college, before they're allowed to operate in patients. And no UK surgeon is allowed to operate on a patient until they've completed their IC training. And this paper went some way to help pave the way for that step. And it's good for patients, it's good for trainees.
Amazing. Correct. So if we go to this concept, like a little more specifically, we wanted to ask the audience what they think, you know, is the where is the place they worry the most to have a posterior capsular break. So this is one of the most important things when we are training somebody. You told us that you found out that 38% reduction of that posterior capsular break, and we want our audience to see, okay, if we are reducing that, where is that happening? And 60% of the people here with us is telling us that happens in quadrant removal. What we're going to do now is we're going to go to the simulator and go to these 4 specific areas. We're going to talk about hydrodissection, we're going to talk about sculpting, we're going to talk about quadrant removal, and irrigation aspiration. So what I'm going to try to do is make the mistakes that a person in training will do in these moments. So if we know what can go wrong, I think it's even better for the brain, you know, to train in a better situation. So right now we're gonna go to the these 4 steps, and we're gonna talk to John, and we're gonna chat about how we can avoid having a posterior capsular break in each of these segments. Let's hope that the audiovisual team is trying to put the signal of the simulator. Okay, I'm here with the simulator, as you can see, and this is very important, right? Because we have the machine and we have many cameras that are showing, they're gonna show my hand position, they're gonna show what's happening in the simulator, and they can also show, you know, the interaction with the machine. You need to remember that this machine has objective metrics that are very good, and they will tell us how did the student perform. So that's also a very important tool to learn, to communicate. This is what happens in the OR, that it's very hard, right? We all think that you can learn like the most in an OR, and that sometimes that's not true, because the communication between the trainer and the student, you know, sometimes is compromised because of lack of time or lack of other things. What do you think about that, John?
Yeah, I think one of the issues is timing. How much time do you spend with a trainee? And I think everybody should have an induction on the IC so they know exactly how it works. And practicing by yourself means you can practice bad habits and get into bad habits. So you do need to be supervised. But there are ways of minimizing, you know, trainers' input. And one of the features of the IC, Marshall was explained to us last night, was being able to look through your recorded videos and share those videos with your consultant and look at the areas where you've made mistakes. And so there are time-saving technologies there that minimize the time your trainer has to be with you. They don't have to be on your shoulder the whole time.
Correct. Marshall, you have been all around the world, seeing trainers from every single continent, every single country. What do you think about this new communication, new way to train the same task in, you know, many different situations and repeatedly? What do you think about that?
I think the thing for someone who spent a lot of time in the operating room in their previous life is you have residents and you have the teacher, but you have a third person, and that third person is the patient. So there's an inherent complexity in that human interaction where by taking the patient out of the learning loop and having essentially the freedom to learn your craft of cataract surgery independent of risk is frankly a liberating thing for both the teacher and the resident, or what they would call in the UK and Australia, a registrar. It's something that I think has changed, and none of us, if we were flying on holiday or to the American Academy, would ever consider flying on an aircraft where the pilot read the manual. They are trained extensively in simulation, and this has changed medical education profoundly. I don't know what your perspective is, John.
Yeah, well, it's this concept of sustained, deliberate practice. And the IC, it's interesting, before the IC, the part of the operation that people find most difficult was the capsulorhexis. And now it's one of the bits that they find easiest because the IC is so incredibly realistic for capsulorhexis training that they find that relatively straightforward. And that's obviously one of the most crucial parts of the operation, because if that goes badly, then the risk of PCRs, we'll discuss later on this evening, is much higher if the rhexis is too small, if it's torn out. And it's just a different dynamic with the teaching. And we see trainees coming through now who just feel much more confident about their surgical abilities. And as you say, it's a safe environment, and it's sort of a nurturing environment. You get a bond with your trainer. And the move to live surgery is definitely smoothed considerably since we have these technologies. It looks like we might be able to get the surgical simulation going now, Ivo.
How's it looking, Ivo?
We're ready to go, guys. So now
Excellent.
you're going to see what's going to happen in simulation. Okay, and we're going to go from these 4 steps. Okay, I'm going to go to hydro maneuvers. I'm going to try to make a couple of mistakes, so we can, people can understand what the importance of this step, what can go wrong, and how can we train our students better.
Okay.
Okay, as you can see there, you're going to see a camera with me and the hand position, and then you're going to see the camera. Can you see me there?
Yeah.
So the first thing I'm doing is into the incision. I'm showing the cannula and the shape of the cannula. That's the important thing. I'm going to be under the anterior capsule, and I'm going to do, incomplete hydrodissection. We're going to talk about this. Why it's important to understand the fluid force, the force you're doing with your hand. Look at this. I'm going to do it correctly, and you can see that it's rotated, it's free. But then if I do it more and I put too much fluid, you're going to see that then we're doing a lot of incorrect things. Okay, guys? And then we're going to talk about it. Let's see here. Let's put more fluid. There you go. We need to understand what happened there. And we also, we need to understand what we can do wrong. And that's something we don't like at all doing cataract, okay? So John, we're hearing you.
Yeah, well, I mean,
how many things did I do wrong?
The people listening this evening only rated that at about 10% chance of, or they're concerned about PC rupture during hydrodissection, and it's quite a rare event. Letting some of the viscoelastic out of the eye before doing the hydrodissection, so the eye isn't as firm as it was when you're making your incision in capsulorhexis. That's a good tip. Getting in the right plane, injecting at a slow and steady rate, and again, the IC is good at teaching you that and not being too forceful. And also, obviously, the morphology of the cataract. If you've got a posterior polar cataract, there's much greater risk of PC rupture. The other thing, in recent times, people who've had multiple anti-VEGF injections, there's a chance of lens touch or lens trauma during one of those injections. So we're seeing a slightly increased incidence of this type of complication occurring early in cataract surgery, where you're performing even just a routine hydrodissection and you can end up with a nasty surprise. So taking the patient's history beforehand, again, very important, but steady injection, not injecting excessively and getting a nice wave, because if you've got an inadequate hydrodissection, then there's increased risk of zonular dialysis later in the operation when you're trying to rotate a nucleus, which isn't freely mobile. But in general, the risk of problems, as you've demonstrated here, it's pretty rare. And the other complications you're going to demonstrate in a minute are probably of more relevance.
Yes, so I wanted to show a correct procedure here while John is talking, and I always like to talk about synchronization. There's so many things happening when you're doing a hydrodissection, and this is like a simple task. I think nobody gives it the real importance in the beginning. It's also something that happens so fast, and that is actually hard to train. But it has, for me, if you deconstruct it, it has many important secrets, right? And for example, let's do it again. And this is right, amazing of simulation. We can repeat it as many times as we want. But I will talk about the correct hand position in the beginning. Okay, correct hand position. Then the correct position of the cannula. I really like to go a little under the anterior capsule and just, I want the fluid to go a little bit up. And then the injection force needs to be short, but it needs to be firm and maintained, okay? And there you saw the wave, but it's not rotating. So you also mentally, you don't stress out, you don't panic, you're not in a rush. You're just trying to do hydrodissection in different places, and then the nucleus can rotate freely. What do you think about that, John?
Yeah, again, just being patient. Sometimes you get a nice wave the whole way around first time. If you don't, just go to a different quadrant, go the same technique. And as you say, don't panic. There's no rush. It's important to get this stage right because it makes the rest of your surgery much easier. And one of the signs we might talk about later on is that pupil snap, where the AC suddenly deepens and the pupil changes shape. If that happens, that just tells you there's been a problem behind the lens that you can't see, and sort of a warning sign that there's been a rupture in the capsule during hydrodissection.
Okay, guys, let's see another of the steps we were talking about. Let's gonna do a divide and conquer. Hope you can see me there. Right there. Please sign all of them. There you go. So let's do a sculpt, right? This was, some people answered that this is a place that we can have some problems, right? If we're doing a sculpt in simulation, you need to do it a little bit slower to have a perfect, sculpt architecture with perfect weight, perfect walls to do the crack. The first important thing we can do when we're sculpting is, we're pushing too hard, and we can do a dialysis right here. But one of the most important things when you are doing the sculpt is you don't understand the correct anatomy of the eye. And right there, right here, when the lens is not that thick, you will go deep and you do this.
Yeah, such a common problem.
That's a big problem, okay? I hope you can see that, because you have almost 100% of the lens in the bag, and you already have a posterior capsular break, as you can see there. So this is a really common mistake in sculpting.
Like a soccer ball or like a football?
I'm sorry?
Is the lens shaped like a soccer ball or like a football?
That's what we don't understand sometimes. We like soccer a lot, so we think it's a soccer ball, but it's
We're a
an
rugby
American football.
European.
So what do you think about that, John?
Yeah, no, it's so important to grasp the concept of the depth of the lens, because early PC ruptures are due to usually one of four things: either the sculpting across too superficially and damaging the rexus, so you get an anterior capsule tear which extends around the back of the eye. If you've got, as Ivo's just demonstrated, sculpting in too peripherally and too deeply and not realizing that the central lens thickness is greater than the peripheral lens thickness. So you rarely have to sculpt out beyond the margins of your capsular rexus if you've got a 5 to 6 millimeter capsular rexus. Phaco settings which are too aggressive is another cause of an early PC tear. And if you're doing a chopping technique, so positioning the chopper anterior on the anterior capsule and chopping the capsule as well as the lens. So those are the four common causes of an early PC tear. But what you've just demonstrated there, when you just pop through the posterior part of the lens through the capsule, that need not necessarily mean there's vitreous loss just at that point. And often you can rectify that situation and remove the lens without, if you recognize the complication early enough. But don't sculpt too peripherally, don't go too deep there, and have phaco settings which have got low vacuum. That's just so important. And don't be in a rush.
I love to talk to you. You know, it's the same things, right? The mental, the mindset skills. Don't be in a rush. Be calm. This is not, you know, a moment to be fast. You need to understand the anatomy of the lens. You need to. What I like is you're seeing here in a big screen is go in position 3, come back in position 1, and do this movement. Okay.
Yeah.
Understand the anatomy of the lens, and the lens is thicker in the center and not that thick in the periphery. That's extremely important to sculpt.
The other concept sometimes trainees are anxious about is, especially in a firmer lens, is using the full phaco power. So if you've got a firm lens, there's a tendency for people to push the probe through the lens. You should never be pushing the phaco probe. It should be leading you through the lens. And if you're finding yourself doing that, and sometimes you're so focused on the tip of the phaco, you don't notice that the whole lens is moving and you're stressing the zonule. So up the phaco power, the ultrasound power, and just let it cut through the lens. If you're pushing, you don't have the ultrasound power high enough. And sometimes when you've got a firm plaque at the bottom, again, it's difficult to engage that plaque. Again, just take your time, pick up an edge, and try and just gently sculpt. You should never be pushing on the lens, because if you do, you'll slide off it and go straight through the softer peripheral lens into the capsule.
I agree 100%. So let's go to what 60% of the people told us that it's, you know, one of the most challenging parts. And this is when you are starting, you are understanding the phaco-dynamics. You eat in almost everything in the of the lens from the bag, and then you have the last quadrant, right? And this is, it's kind of obvious that you don't have the stability of an entire lens in the bag. And second, you also need to be very aware of what's happening, how the anterior chamber is behaving, and of course of phaco-dynamics, because this is the riskiest part. Research show us that this is the moment when we always have, the most posterior capsular breaks. So guess what? Let's train exactly that. And this is, for students, I think it's amazing. So let's get into it, and let's see what happens. Maybe I break something. Okay, so we start in position 1. One important thing, let's talk about good tips is, to have the correct position of the phaco tip This, I see this a lot, and this is incorrect because you can see, the infusion going to the endothelium. That could be a problem for the next day when you see white corneas and you don't know why. What I like is, in position two, to go to the fragment and then hold it, right? And when you hold it, there is one big problem here. Dr. Ferreira forgot to change the OR settings, and we were in sculpting.
Removal, you're still in sculpt.
Exactly. We were in sculpting. So what happened there? The fragment will come to me. Okay, so in position two, let's see how it behaves completely different. And I have it. I can bring it to a safety zone, and then I start eating it with enough ultrasound to just to do it. But when I have here, sometimes this happens, right? And I have a posterior capsular break. And we could talk about 3 or 4 hours about what happens in this exact moment, okay? But we are in the moment that we need to avoid this to happen. So John, tell me what you tell your students to avoid to this to happen in the last fragment.
First, when you've got the last fragment, there's this tendency to think, oh, we're nearly there, we're nearly finished, let's rush and get that last segment out. And to have having the second instrument in the eye, people get a false sense of security that by having that second instrument below the phaco probe, it's going to prevent the posterior capsule coming up to the probe. But actually the fluidics of the modern phaco systems means that it's much safer to do what you were doing, Ivo, which is just have the phaco probe in the eye. As long as your side ports are of normal size and you've got a good seal around the phaco probe, you've got very little egress of fluid from the eye. You've got a control situation. Do as you've done using the vacuum, pull that quadrant into that safe cylinder zone within the middle of the capsule. Don't go chasing bits of lens fragment into the periphery, and just gently bring it forward. The mistake people make is they go chasing it, or they've got a second instrument in the eye, fluids leaking out of the eye, and the capsule, especially a loose baggy capsule, can still come up around the second instrument and snag the thing. But the crucial thing, is we'll demonstrate in videos later on this evening, is when that happens, when you've recognized that you have primed the capsule, don't panic, stay calm, and do not remove the phaco probe from the eye, because you've probably just got a small tear there, and if you take the probe out of the eye at this point, it collapses the anterior chamber, the vitreous pressure increases, and the PC tear increases in size. So we'll talk later on about what to do when you've had that complication. But
okay, yeah, I agree. We could talk also hours about phaco how to be aware of that, of how to behave in those last fragments, to see your parameters, to always try to do ultrasound when the tip is occluded, or at least 80% occluded. And we're gonna go fast to INA. A lot of people here also told us that this is the step that they're more afraid to have a posterior capsular break. And let's try to do some bad things here too, so we can move forward, because today it's a long and there's a lot of things to keep learning from anterior vitrectomy. So I have here coaxial, irrigation aspiration tip, and this is the correct thing to do, just to go for the fragments behind the anterior capsule, to grab them, and when I know I have them, I will bring it to the center and do it. But when we are almost all the time in the last, in the last cortex that is here, like subincisional, there is when the problems happens. And there's many mistakes we can do. We can go for the cortex that is close to the posterior capsule. We can break it like this, and then we have a problem. But we can also, grab the anterior capsule. Let's try to do it here. Well, actually, I did it pretty good, but we can, like this can happen too, the anterior capsule, and that's a problem. And we can break also the posterior capsule right like this, right? When we're in the subincisional part.
Yeah.
And you know, the eye is very nice to us, but you know, we could do this easily in a human being. John, tell me about this step.
I must admit, I prefer to use the bimanual, so it's easier to get that subincisional cortex, or you can use a curved or a hockey stick type instrument to make it easier to remove that cortex underneath your incision. I feel that bimanual just gives you a little bit more stability for that. But again, it's recognizing those subtle signs. If you see that slight puckering of the posterior capsule because you've picked it up in your probe, don't panic, just hit the reflex button so it reflexes. And again, if you've picked up the anterior capsule, you'll notice that you can sometimes see the zonule if you're pulling on the anterior capsule. And with the IC, again, you can simulate this and get used to recognizing those early warning signs that you're aspirating the wrong thing. Silicon tips INAs, which you can't get for a bimanual yet, I don't believe, but for the single probe, they've dramatically reduced PC rupture during cortical aspiration. In fact, my colleagues who use them feel it's almost impossible to rupture the PC if you've got one of the silicon tips on the aspirator. So that's been a big advance in the last 3 or 4 years.
Coming back to these 3 pillars, people who are following us in different virtual classes and webinars, they understand that we like to divide cataract surgery in these 3 important pillars. Okay, the motor skills, we're talking always about the motor skills, what to do, what not to do into chamber, hand position, and pivoting through the incision. But we're also talking about the cognitive skills, the decision making. So please, we're gonna ask the audience to talk about that, you know, the decision-making process in every single of these 4 steps, and also the mindset skills. I'm so happy that John keeps talking about the mindset of the surgeon in that moment. What do we do when that happens? And I think that's very important. What happens if we panic? If we panic, the problem is we don't make correct decisions. And for that, in Ophthalmo University, we have developed these 3 tools for each of the pillars. We have a Phaco motor skills program to understand how our fine movements inside the eye, hand position, and how we can move through an incision. In the cognitive skills, we believe that we can have an algorithm for everything, right? The correct algorithm for every single situation, a correct decision-making process, yeah, to be aware of what's happening. These are skills that you can train and you can improve as a surgeon. And the mindset skills, you keep talking about them, John. So please talk to me about what do you think about the training in the mind? We are fans about training the minds of a surgeon.
Well, training the mind, I've been doing a little bit of work with colleagues who are sports coaches and training athletes because there's a lot of similarities between certain sports and cataract surgery, and in particular golf. It's very much a sort of a solo sport and demands fine motor control, but a lot of professional golfers, what distinguishes the great golfers from the average ones is their mental strength and resilience. And of course, their attitude to practice. And this is where simulation comes in, because it's easier to have a positive mindset when it comes to managing a complication if you've had the opportunity to practice it many times. So you're therefore more relaxed when it happens. You still feel bad when it happens, but at least you feel you have the tools to then go on and deal with it. And this was an interesting survey carried out by the Ophthalmic Trainees Group in the UK a number of years ago, which looked at our trainees' confidence in performing cataract surgery solo and also anterior vitrectomy solo. Just go back a slide. So in the UK, you have to have completed a minimum of 350 cases by the end of your 7-year training program. And as you can see, most of the senior trainees were very confident performing Phaco by themselves, but only about 20% of our trainees were confident in performing an anterior vitrectomy following posterior capsule rupture by themselves. And this is almost, if you like, one of the problems in inverted commas with simulation, because by reducing the PCR rate, there are many fewer opportunities in live surgery to actually perform an anterior vitrectomy, and even more reason why simulation is important. And that's why in the UK we've tried to introduce not only the IC but model eye training, so people feel more confident when this happens. And I suspect if the same survey was carried out in Latin America or in the US or in Europe, most trainees would probably feel the same.
I love this part, John. Seriously, I think people are understanding that the story, it's about two important things. The first thing is that our learning curve can improve so much with tools like virtual simulation. We can reduce 38% of posterior capsular breaks. We show people how, the mistakes that we can make and how we can train about them. But this, it's another very important part of this class. And it's like, if you have a better learning curve and you are learning better and you have better outcomes, then you don't get to train in complications. And this is very important for a good surgeon. So we can do that also in the machine. And that's the second part of the class, right? I think it's very important. What do you think, John?
Yeah, it's really important. We tend to use the IC again to pick up those sort of fine motor skills, but then transfer it to make it a more immersive simulation using model eyes in one's own theater, with your own microscope, with your own vitrectomy machine, with your own theater team. So you can put into practice what you've learned on the IC with a more sort of real life situation. And it's not just PC rupture that you can practice managing zonular dialysis, suprachoroidal hemorrhages, and make it a bit more like aviation simulation, where you don't know what the complication is going to be. The model eyes can be set up by your trainer to perform in an unpredictable way, and that becomes really like a real life situation.
Great. So let's do then an anterior vitrectomy, and let's do a couple of mistakes. Hope you can see them. And the good thing about simulation is that there you go. The good thing about simulation is that we can have different scenarios. And here in anterior vitrectomy, we're going to have probably 8 or 9 different scenarios. And this is something that maybe doesn't happen in a human being, but it's so good to train and so good to talk about the principles of anterior vitrectomy. In this case, I hope you can see that from the quality, and you have a complete capsular break, and then you have vitreous already stained. So the student can understand the vitreous, can understand how vitreous behaves, and you can do an anterior vitrectomy. And let's do one, and we were talking about this with the Spanish speaker before, but let's do one. And please, I ask the audience to see how many mistakes I'm gonna do, and then we can do it correctly. So let's start. Okay, I'm doing an anterior vitrectomy. It seems obvious, right? I will start eating the vitreous that is close to me. But as you can see, something is happening, right? I see more vitreous, and vitreous keeps coming and keeps coming here. Oops, I'm hurting a couple of structures and they don't like that. And I can also, hurt the posterior capsule. Maybe I'm moving a lot. Okay, so I'm doing many mistakes. John, tell us about not only my mistakes, but how do you train your students when they do something like this?
Well, hopefully you don't do something like that to start with. But if you've ruptured the capsule, again, this in the example you've shown there, it's happened during aspiration of cortex, shall we say. So you're tamponading the eye, you're putting viscoelastic in to tamponade the vitreous face, putting in your triamcinolone to identify the vitreous. The principles are cutting the vitreous using high cut rates, low vacuum, relatively low flow, and by removing the vitreous, you mustn't pull on the vitreous. By pulling on the vitreous, you're high risk of causing a retinal break and a retinal detachment. And having a regimented way of dealing with the vitreous, going to the bit around the posterior capsule first, clearing out that capsular bag. In this instance, there was no cortex left behind, which is a slightly artificial scenario. There's normally cortex as well. And I have the machine set up so that I can go from cut to IA by kicking the foot pedal to the right on the Alcon machine. Being very mindful of the position of the capsular axis, because preserving the capsular axis is key. We're presuming that it hasn't been damaged earlier on in the operation, because then you have a nice platform for your sulcus lens, and also not going in front of the anterior capsule and damaging the iris. And in the videos you might show later, making sure you've no vitreous strands left behind coming up to the side ports or coming up to the wound. But at all costs, you must try and preserve the anterior capsule and keep that capsular axis intact.
Let's do another one, but a little bit better. Okay. So we can talk about, you know, what we call the principles of anterior vitrectomy. See if you can see there. There you go. Okay, I'll wait. This is for next time. Let's do again the same, you know, task that is a little bit simpler. There you go. Okay, so again, we have a posterior capsular break, vitreous stain in the anterior chamber. I'm going to start some important thing. I'm going to start with irrigation first. This is a bimanual vitrectomy. And look at this. It's completely different, right? There's some vitreous coming to the main incision, but I behave it completely differently. So vitreous, instead of, actually, I didn't do pretty good in this one. And that's the good thing, to talk about it. And you can see where I'm right there, right? I'm below the level of the posterior capsule. I'm not breaking anything, but I'm below. So if I take the instruments away, you know, the machine is saying I did pretty good. Actually, I wasn't, we're gonna share right now what the machine is telling us. This is very important. Okay, if we can do a little zoom here, what we're gonna do is to tell you the metrics, because this is very important to train, right? This is a machine telling you objectively how you did. And if we understand what the machine is measuring, you can learn even from that. And here, it gave me a pretty good score. It was 96 over 100. Let's see if you can see there, and everything excellent. But I did pretty bad in the one before, right? And what we can learn from that is, here I behaved completely different. It was an hermetic anterior chamber. I went down and I wanted the vitreous to go back. I was not pulling vitreous more and more. And this is very important, because the machine will penalize you if you bring vitreous from the posterior chamber to the anterior chamber. This is extremely important. It will also tell you how much vitreous you left in the anterior chamber. It will tell you how many vitreous is below the posterior capsule. So they're very important concepts, you know. It's talking about efficiency. It's talking about instrument handling. Are you managing the instruments correctly? Are you treating the tissue correctly? As you saw in the first anterior vitrectomy, I was, you know, damaging the iris, damaging the anterior capsule. I love what you said, John, about just thinking ahead, right? Thinking it's the anterior capsule is so important for me, because that's where the lens is gonna be supported. So that's extremely important in my decision making. What do you think about this new performance, John?
Yeah, well, that's much more like it, really, isn't it, Ivo? Much more controlled, and also with your irrigation, not being delving down in towards the posterior capsule with your irrigation, stirring up more vitreous, and just making your life harder for yourself. But in that simulation, you've got a little bit of cortex, and so the next simulation, you've got some cortex as well as vitreous. So maybe move on to that, because that's a more common scenario where you still have a mixture of vitreous and cortex left behind, and then you're having to swap from cut mode to remove the vitreous with triamcinolone, then aspirating some cortex, then going back to vitrectomy mode and going back and forward patiently to remove not only the vitreous, but also the cortex. Have you got that simulation up and?
Yes, yes. First of all, let's see if we can show a little bit about the parameters you use. I think this is very important. It's a very common, the slide, very common question when we're doing vitrectomy about which are the parameters we use. They're in Spanish, but I'm pretty sure you know them and you know the machine. And basically it's about the cut rate, because there's three things happening, right? Cut rate, IOP or bottle height, vacuum, and aspiration flow. Tell me a little bit about how you manage this, John.
I usually give cut rate between 2,000 and 3,000. So maybe not as high as the VR surgeons, and relatively low bottle heights, low vacuums. But it's the cut rate, because you don't want to be pulling on the vitreous, so you're relying on a high cut rate, adequate vacuum, which again you can control with the foot pedal. But then again, that's the beauty of practicing in your own theatre, with the settings and experimenting with them beforehand, which you can do with the model eyes, so you're familiar with it. But this brings us on to a topic we'll talk about at the end, which is no matter how brilliant a surgeon you are, if you're a scrub nurse who's assisting you is not familiar with the machine and the settings, then that can add to the stress of the situation. So team simulation, which we'll touch on at the end, is important. And having the correct anterior vitrectomy settings is absolutely essential to get a good result.
Great. So let's go for the simulation you were asking. So this one was a little bit easier, and to talk about the anterior vitrectomy principles. But now let's go to anterior vitrectomy that has many issues. I'm going to say what you guys are going to see. I hope you can see them, because right now you need to be making a lot of decisions, right? This is a lot about problem solving and decision making. So let's see what's coming out from the simulator. You can see there how I can it's amazing how I can set everything. So guys, what do you see there? This is very important, right? I hope the quality of the image is good for you, but we are seeing cortex, we're seeing a posterior capsular break, and we are also seeing the iris not behaving correctly. We see some traction there. So probably there is something. And the machine, the amazing thing about the machine is it allowed us to make decisions. What do you guys want to do? You want to put dispersive viscoelastic? You want to put triamcinolone and stain the vitreous to see better? Do you want to go for the cortex, or do you want to go for the vitreous that you can see there, right? And this is the important thing in anterior vitrectomy, the decision making, what you're seeing and what your plan is going to be. So imagine to train this again without the human being, with a mentor next to you, communicating in a good way, having objective outcomes, and also, the most important thing, you can repeat it as many times as you want. So let's see. You're going to see here. Let's do something. Let's stain it in the beginning for you to understand where vitreous is. I hope you're seeing. Okay. We can stain it. And after we stain it, we can put dispersive viscoelastic. Okay, so now you can see perfectly what's going on. Right? You have vitreous. The vitreous is attached to the iris, and you also have you also have some cortex. So what would you do? Would you go to vitreous? Would you go to cortex? I leave that to you, and we're going to discuss that. Let's do some vitrectomy, okay? Let's do some anterior vitrectomy. And again, let's do it kind of decently. So we're applying the principle that, everything goes back, and we're not pulling vitreous up, and we are detaching the vitreous from the posterior chamber of the anterior chamber. Yes, and we are always protecting structures, but what's going to happen here? Okay, vitreous is coming, but this is, sometimes it's very sticky. We need to understand how vitreous behaves and try to manage it. There you go. I did it perfectly, but sometimes you can go with the spatula, okay, and also just and also move vitreous from when it's in the endothelium, on iris, on the capsule, and the spatula can be a very useful tool. And now that we don't have vitreous in the anterior chamber, we can go for the cortex. We can go, let's go bimanually, because you told me that you use bimanual, right, John?
Yes.
Okay. Okay, so we can go bimanually and then remove the cortex. But this seems easy, guys. I know sometimes, but it's not that easy when you have to do it. And the decision-making process is something amazing for you to train yourself before you.
At this point, Ivo, because that looks lovely, and occasionally it happens like that, but perhaps more commonly when you've removed the vitreous, as you have done, and removed the bit that's coming to the paracentesis or to the section, you remove a little bit of the cortex and then more vitreous comes forward and you're wondering why the cortex isn't coming. It's because there's more vitreous present. Then you just have to repeat what you've just done, put in more triamcinolone, identify the vitreous, go back to your vitrector, remove that, and then go back to the cortex, and just be patient going through those steps until you've removed all of the cortex and the vitreous.
Great, and we agree. We have a second question for the audience. It's very important. I would like to, to make it perfectly clear that we want to know which is the most important thing you struggle the most. So here, we want you to understand, if you understand the characteristics of the tissue you're handling, vitreous behaves differently, as we were talking about. We need to know if you want to, it's not clear for you to optimize fluidic settings, or you are in lack of opportunity to train this kind of procedure. I have to be honest. Almost 80-90% of people I talk to in different parts of the world, they tell me that even in a fellowship, even doing an anterior segment fellow, they don't have the ability to do anterior vitrectomy. So this is the place to be, right? We need to train better and try to avoid the posterior capsular break, but then we need to be good in anterior vitrectomy. And the answers are what we suspected. The problem is sometimes is the lack of opportunity to train the management of anterior vitrectomy. What do you think, John? Because I know you guys are amazing in training this. It's very important, right?
It's not at all surprising. And the IC, I'm a huge fan of the IC, but unlike in the UK, there's many parts of the world where access to an IC would either be limited or just at the moment, at this point in time, not possible at all. But as we'll see in some of the other videos coming up, there are other ways of practicing this. One of the comments from one of the viewers today, Jason, wanted to know when do you know you've finished? What's the end point? And the end point, Jason, really in the simulations that Ivo's just demonstrated is when you have a nice regular pupil, which with triamcinolone shows no staining up to the vitreous ports and all the cortex is removed. And you can never put in too much triamcinolone or do it too many times just to identify any residual little strands, because there's nothing more frustrating than having a slightly peaked pupil the next day. So that's the end point, a nice well-formed anterior chamber, an intact capsular axis with no vitreous strands to the wound. This is a nice video here showing just removing all of those strands. And don't be afraid to switch hands, so moving your vitrector from your right to the left hand. In Ivo's, the first video he showed there, he is managing to remove the vitreous strand using the instrument in his right hand. But if that's not possible, swap to the left hand and use that to cut underneath the opening of the paracentesis without damaging the iris.
Yes, I think this is an amazing video that we can have since we're doing virtual reality and we have, we can see the eye from above. But since this is data, you can reconstruct it and have a side view of what's happening and look about well, for me, there are the vitrectomy, anterior vitrectomy principles, right? The first one is an hermetic anterior chamber. As you can see there, you don't have a negative pressure and things coming out. I see so many people with the vitrector in the main incision, then you have a negative pressure there and vitreous keeps pulling, right? And the second thing is, I think it was pretty clear in the second simulation, that is, you need to grab the vitreous from behind. It's better to detach it from the posterior chamber with the anterior chamber, so vitreous will go back. And that's one of the main reasons of people who defend pars plana vitrectomy. Always try to do a bimanual anterior vitrectomy because you have more control of structures. And as you can see there, remember I was telling you about vitreous being sticky in structures. You can see that vitreous can be very sticky in the iris. So virtual reality give us these amazing videos with a side view and when you can understand how to manage better.
And that video shows nicely how you can turn the instrument slightly on its side, but not completely, just to pull the vitreous. You mustn't turn it upside down or even past 90 degrees because it will pick up the iris or the capsule. You're almost polishing the iris with the undersurface of the vitrector to remove the vitreous. Great.
We're almost finishing, but this is one of my favorite parts. This is the fire drill for PCR that John has, there with the students and with their team. And I think sometimes in Latin America, we lack of preparation. Sometimes you are doing an anterior vitrectomy, nobody knows where the anterior vitrector is or how to plug in and how it works. So please explain us this fire drill, for PCR that I think is an amazing concept.
Well, this concept was really popularized by David Lockington, who's a friend and colleague who works in Glasgow in Scotland. And he's published on this concept of the fire drill, which is an immersive simulation for not only the surgeon, but the scrub nurse and the runner in theater. Because you can have done all this simulation we've talked about, but if the rest of the theater team aren't prepared to provide the instruments you need at the right time, then you're unlikely to get a good outcome. And you can practice not only posterior capsular rupture, but zonular dialysis using a capsular tension ring and other problems. And David's tips really are to have all the equipment you'd require for an anterior vitrectomy in a small box or in a bag here. You've got myocol, you've got Kenalog, triamcinolone, Tenno, nylon, your anterior vitrectomy. It's easily to hand. It's located on a shelf beside the Phaco machine or a cupboard. And also you can practice what Larry Benjamin, one of the great cataract trainers in the world, talks about, his dinner party voice. So when you require the anterior vitrector, it's like being at a posh restaurant where you'd say, Ivo, please could you pass me the salt and pepper, with a very polite voice and in a calm way, so the patient doesn't realize that there's a potential complication. So it's being able to say to the staff nurse or the theater sister, please could you pass me the anterior vitrector? That means everybody's calm, nobody gets in a flap, the equipment's readily to hand, and then you can perform the technique correctly, knowing you don't have the stress of wondering, will they hand me the right piece of equipment? So everybody can practice this fire drill. I don't know if you have the slide, the videos that we had last night of just the model eye simulation, just to show how people could practice that in their theater. That was on the original deck.
Yes, we're gonna finish with that video. But before, we just wanted to give the audience the last look of the simulator in this specific case. That the thing here is you're doing, as you can see there, there is no posterior capsular break, and we can talk about another a very important concept of anterior vitrectomy, that is the transition of what happens, as we said before, not only you see I'm doing here, I'm doing and suddenly, wow, did you see that? You know, it was a very big posterior capsular break, and what I did is I went out fast. Why? Because everybody wants to do that. You know, you get afraid and you get out of the anterior chamber. And the problem is that vitreous will come up to you, and you're not going to have an emergent chamber. So the important thing for transition is to, as John says, be relaxed, be calm. You know, stay in position 1. Put viscoelastic, dispersive viscoelastic in the anterior chamber. Then you take the irrigation aspiration or the Phaco tip. That's a very important thing we can train here too. And then again, we go to slides. We go to the vitreous and then to the cortex. Just to finish, John is going to show us an amazing video he did with artificial eyes, and we're going to start, answering some questions in order to time for you guys. So then again, we're building all these principles for anterior vitrectomy. It's very important to understand what happens in virtual reality, in artificial eyes. They're complementary. You know, they're amazing tools for you guys to be amazing anterior vitrectomists. Okay, so this is what we need to do. Anterior vitrectomy should be another step for cataract surgery. You need to be an expert in that. In the moment you're an expert in that, you will not be afraid of it, and you will perform it perfectly. And guess what? Patients in the next 24 hours, they're great. If you do a nice anterior vitrectomy, you know, IOL on sulcus, patients are very good, maybe in 1 week, but they have amazing outcomes. So please, John, tell us about this amazing video.
Well, these, I think, is the commentary running on it? No. So this is a model eye from Philips Studios, the Simulated Ocular Surgery website, and the linked simulation gallery of all these videos for free. Anybody can watch them. So the model eye has been filled up with an egg white solution, and this is artificial triamcinolone. It's made from saline, white paint, and a calcium salt. And you can see when it reacts with the egg white, you get a really vitreous-like tenacious material. So the eye is simulating a PC rupture. We're using the skills that we've learned on the IC now to go in to the eye in your theater with your microscope, with your settings on the vitrector, and practice removing this tenacious vitreous material away from the anterior surface of the iris. This eye doesn't have a capsule, but our more recent eyes have got an anterior capsulorhexis to avoid. And you can spend as long as you like practicing these techniques by filling up the eye with more of the egg white solution, using the triamcinolone, using your right hand, using your left hand, getting your fingers wet, and getting confident. There's nothing magical about the vitrectomy instrumentation. There's nothing sort of mystical about it. It's just practice using them in this controlled environment. And some of the eyes which we use for phaco surgery can be intentionally damaged, so you can break the posterior capsule. Your trainer can without telling you. So when you're carrying out a phaco operation, the PC will rupture, and you'll have to deal with the management of an early PC tear. But these eyes are great for practicing the techniques which you've learned on the IC. And if you go on the Simulation Gallery website, you can watch the videos. There's the recipe for the vitreous substitute, the recipe for the triamcinolone, and the eyes can be used multiple times. So they're just not single use. These eyes can be used many, many times to simulate the vitreous.
Maybe we can take some audience questions now in the interest of time. That's an amazing video, John. And my first experience with using egg white with a staining agent was complements of use. So you've taught me a lot about how to maximize the opportunity to help young people learn without patience. So the first question, and I have to believe this guy has done some cataract surgery. William Dean says, good phaco is done with the pedal, not the hand. I'd like you experienced teachers, Dr. Ferris and Dr. Evo, to speak to that. We've talked a lot about what's happening in the eye, but there's a foot under the bed, and it's really driving the bus.
Well, Will's a very good friend of mine, consultant colleague, and is one of the world's top experts in simulation. In fact, he's carried out randomized controlled trials in Africa for the last 3 years, looking at simulation for small incision cataract surgery and trabeculectomy. So look out for hopefully his papers coming out in the next year or two. And he's a high volume cataract surgeon, and he's absolutely right. The point I was trying to make earlier on this evening was not pushing the lens, and Will, in his teaching of trainees, said using the foot pedal to guide the ultrasound delivery, and that's what he means by phacoing with your foot, not with the handpiece, because too often people are too tentative with their foot on the accelerator, if you like. They're not using enough ultrasound power. And I saw that Will's comment come up earlier, so I'm glad, Marshall, that you read that out. Very, very important point.
Exactly. That's why I prefaced it with, this guy's done some cataracts, because that was spot on. Let's go to Patricia Paca's question. And this related more to, hey, what are those skills that would help me avoid having a PC rupture? And she asked a very interesting question about, how about when you're in that last lens fragment, that last piece? Is it okay? Or what would you do? Maybe put some visco behind the lens? Is that necessary in your estimation?
No.
Okay.
With the modern fluidics, if you've made your paracenteses, the right size, and you've got a nice seal around the phaco, Brian Little's teaching in the UK, and Larry Benjamin again, is just take the second instrument out of the eye, engage that quadrant with the vacuum, bring it to a safe position, and it's perfectly safe then to use a reasonable amount of ultrasound to remove that last fragment. The fewer instruments you have in the eye, the less chance the chamber is going to collapse and you're going to have a problem. There's no need to put viscoelastic behind that last quadrant.
Amazing.
In every case. I agree.
What do you think, Ivo?
I agree. Are you watching me there? I just want to play with the machine. I'm here. Want to do something extra with the machine, because I think this is so good to train during this entire. There's going to be hard times for fellows, for residents who are training and trying to learn. Surgery is going to be. It's not going to be that frequent, at least in many countries. So I really wanted to go back to how much we can learn during this time, how we can prepare ourselves to that moment that we can start doing some surgery again. So I would love to keep doing this with you guys. We're going to have other episodes in the future. Okay, so feel free to ask all the questions you want. For matters of time, we're not going to be able to answer every of them, but you can follow us on social media or via email and ask everything you want, and we will be happy to answer that. I really want to go back to the 3 pillars we were talking about, and I'm so happy that I see John training people in the cognitive area, like we like, right, with the decision making, but also with the mind skills. So just to finish, for matters of time, John, what are your final thoughts about how we can better prepare mentally to be the best surgeons we can be?
That's a topic for a whole other webinar. In fact, one of my trainees who's doing a master's in surgical education is currently surveying experienced consultants, asking them for their tips on this topic and comparing their thoughts with professional sports people. So hopefully in the next year or so, Sarah Szymanski's research will come up with some really helpful tips for trainees. But I would just go back to the points we were making earlier, in that practice gives you confidence. Confidence then leads to better results. And even when you have a complication, if you've practiced it, you feel more relaxed. And one of the points you were making earlier is that please just avoid that denial phase. When a complication has arisen, you know what the signs are, accept it, take a deep breath, and deal with it in the correct way. Don't rush, try not to panic, and put into practice what you've been learning on the simulator. There's a very good book by a chap called Dave Allred called The Pressure Principle. He's one of the world's top sports coaches, and I would really recommend people read that because there's lots of fantastic tips about creating the right mindset, his ideas about practice and dealing with adverse outcomes. It's called The Pressure Principle by Dave Allred, and it's a fantastic read and applicable to all areas of our life, not just surgery. So if people want to know about dealing with pressure and a positive mindset and dealing with complications or problems, I would really recommend that book as a good read. And in this period of lockdown, we've got plenty of time to do reading. So I would suggest that would,
thank you for that. People who know me, they know that I like to read a lot, and for sure I'm going to read that. Thank you for that, for recommending us that book. Marshall, do you have any other questions, or should we be closing?
Yeah, we had a number of really great questions. If we have a moment, we could speak.
Yes, that's great.
So I want to ask, there's a very basic fluidics question from Enrique Della Torre, who wanted, gentlemen, for you to clarify, in addition to the cut rate, what's the appropriate bottle height setting and aspiration setting so that he's comfortable setting up a vitrectomy setting?
Well, I normally have the bottle height at about 70 or to start with, and just depending on how the eye's behaving. But if you've made your nice little fine side port incisions and you're not putting any instruments through the main wound, that's a pretty reasonable bottle height, and a vacuum of 100, 120, 150, so low vacuum. But again, you can control that on the foot pedal. I don't know, Ivo, what you tend to use.
I agree with you, the same. But there is something I wanted to put this image, because there is something very important when we are doing an anterior vitrectomy, and this mode that we have, and we can do first anterior vitrectomy and then aspiration, or we can do aspiration and then do the anterior vitrectomy and cut. And this is very important, and I see many people around that they don't see this function, and that's why we put two images. And this is because when you, for example, when you are doing anterior vitrectomy, you put anterior vitrectomy first with a high cut. But then when you have cortex, you can sometimes go with the anterior vitrectory itself, but it's better to put it in the second mode to do some aspiration.
Absolutely.
Yeah, that was a great question, and I wanted to make that point. Do you have any other, Marshall?
Yeah, I think there's two. One quick one from Luis Lowe. Gentlemen, so what's your opinion on using regular triamcinolone versus a preservative-free version?
That's for you, John. That's for you, John, because this is very interesting. In our school here in Mexico, we don't use triamcinolone a lot. We are a lot of surgeons that we don't use triamcinolone that frequent.
Okay, so that would be option 3, or
exactly.
not at all.
Not use it. What about you, John?
Yeah, no, I use it all the time. There's a very good paper by Larry Benjamin and David Lockington recently talking about the false economy of not using extra instrumentation or materials during cataract surgery. For example, not going for a capsular tension ring or Aris hooks or Malugan ring or triamcinolone, thinking that you don't need it, but actually in the longer term it leads to more complicated surgery and more poor outcomes, especially in anterior vitrectomy. It's very hard to reveal all of the vitreous without triamcinolone. I think it's essential, really. So I would encourage people to use it, especially in PC rupture, because you just cannot successfully identify all of the vitreous up to the ports without it in some cases.
Especially with shaky technique, you know, you're just pulling more up. And let's wrap up with the ever open for debate question of approach. So Alvaro Ortiz asked the very common question in these kinds of conversations of, what do you gentlemen think about using a pars plana approach?
The eternal question, right?
I knew it.
You go to any meeting in the US, Oscars or anyone, and everybody will be doing a pars plana vitrectomy. You go to many other parts of the world, and I think they mostly do from the anterior chamber. My humble opinion is I always put, like, you know, pros and cons.
Right.
I don't do a pars plana vitrectomy for a couple of reasons, but mostly because I think that the pros of the pars plana vitrectomy, they don't, you know, they're not that much benefit because of the risk. Because I'm a person who is not training to manage vitreous in the posterior chamber. You know, I know my visualization is not going to be good, and I know there's going to be vitreous in the base of the vitreous that I'm not going to reach, and I can have some problems. So what I teach and what I like is to do an anterior approach and go deep. Actually, I have a friend that had a funny saying that it's go as far as the microscope lets you. Go deep, but from the anterior chamber, you know, and try not to hurt the posterior capsule, but always from an anterior approach. What do you think, John?
Yeah, even the VR surgeons in the UK, the vast majority will manage their posterior capsular ruptures with an anterior approach, even though they're trained, you know, VR surgeons.
Oh, really? Oh, that's an interesting one.
You know,
so even the retina
approach. I mean, obviously, if the nucleus has been dropped, then they will take over and do a posterior approach. But if when they're carrying out a cataract operation, a routine cataract, not a phaco vitrectomy, but they will manage that via the anterior approach. If you're doing a phaco and an epiretinal membrane peel and you break the capsule, then they'll do it from the posterior approach. But for a routine cataract, they will, in the vast majority of cases, you perform an anterior vitrectomy.
That's a good one. We could have an amazing debate between a retina surgeon from UK and an anterior segment surgeon from the US, right? It would be very interesting.
That would be interesting.
Okay.
I knew that would be a hot question, so I left it for last. So unless you gentlemen have some last comments before we wrap up, I think it's been an amazing discussion. And thank you, Dr. Ivo, for organizing this on such short notice, and for Dr. Ferris for extending your week after working in a COVID clinic in the UK, only to come and share your knowledge with us. So thank you so much.
It's a pleasure. It's really been a very interesting and enjoyable setup. Well done, Ivo. The technology was amazing. For those that are live surgery, congratulations.
No, thank you, John. It's a pleasure to have you. I have to say that this has been very hard to do, I have to be honest, but it has been a teamwork. People from audiovisual had been amazing. You cannot imagine how many things are going on in the same time. Point laboratories help us with the simulator and with the audiovisual. Marshall has been working a lot for everything to go right. So this is, again, like, as a team, right? We're stronger as a team. I want to thank everybody. But we really wanted to do this. We really wanted, passion drove us to give you everything we can in these hard moments that people are not doing surgery, for you to keep improving and maintain your skills during these, you know, adverse moments. So thank you all, and well, hope to see you in volume 2, right?
Yeah, absolutely.
Okay. So bye-bye, guys.
Bye.